Episode 2: The Clinical Presentation. A woman in her early 30s develops a painful breast mass. It is red. It is swollen. Ultrasound shows a collection. She gets antibiotics. It improves a little, then comes back. A second abscess forms. The skin retracts. Now someone says the word cancer. This is the clinical nightmare of granulomatous mastitis. Welcome to Episode 2. Today, I want to focus on what patients actually experience and what clinicians actually see when granulomatous mastitis is associated with the Corynebacterium croppenstedii complex. The most common presentation is a painful breast mass. Erythema, warmth, and swelling are common. Around one-third of patients in older GM series have an abscess-like presentation. Some develop fistulas or draining sinuses. Some get ulceration, nipple or skin retraction, and a minority have lymphadenopathy. The problem is that none of those findings is specific. A regular pyogenic abscess can look like this. Tuberculosis can look like this. Fungal disease can look like this. Sarcoidosis and other inflammatory disorders can look like this. And breast cancer, especially inflammatory breast cancer, can look frighteningly similar. Why imaging does not solve it. Ultrasound may show hypoechoic masses, fluid collections, cavities, or fistulous tracts. Mammography may show asymmetric density or may be surprisingly unrevealing. MRI may show rim-enhancing lesions that look like abscesses. These tests are essential for anatomy and cancer evaluation, but no imaging sign says this is definitely Corynebacterium granulomatous mastitis. One of the cases I recently reviewed in a paper is a perfect example. A 37-year-old woman had recurrent non-lactational mastitis and abscesses. She received several short antibiotic courses. Initial aspiration cultures were negative. MRI showed rim-enhancing lesions. Because malignancy was still a concern, she underwent drainage and biopsy. Histology showed cystic neutrophilic granulomatous mastitis, with faint bacterial rods near small cystic spaces. Later, the culture grew C. croppenstedii. That case illustrates the entire disease in miniature. Recurrent inflammation, negative initial cultures, a cancer concern, granulomatous pathology, and finally a microbiologic diagnosis. What does Corynebacterium-positive disease look like? Recent cohorts suggest that Corynebacterium-positive GM may be more aggressive locally. In a 2023 study, patients with a positive C. croppenstedii result had larger masses, more sinus formation, more recurrence, and a longer time to complete remission. In a 2025 species-resolved study, C. pseudocroppenstedii was associated with more pus and more recurrence than C. paracroppenstedii. That does not mean you can diagnose the species from the physical exam, but it tells us something important. When we find these organisms in a deep, compatible specimen, they are not necessarily innocent bystanders. The patient experience. This disease can last months. In one cohort, the median time to complete remission was about 5 months, and longer in the Corynebacterium-positive group. Patients may have repeated aspirations, courses of antibiotics, dressings for draining sinuses, biopsies, and sometimes surgery. They may be told it is infection by one clinician, autoimmune disease by another, and probably nothing by someone else. For patients listening, granulomatous mastitis is benign, but benign does not mean trivial. It can be painful, recurrent, disfiguring, and emotionally exhausting. And because it can mimic cancer, a proper evaluation is important. The goal is not to panic, and also not to dismiss it. When should a clinician think about CKC? I become much more suspicious when I see recurrent non-lactational mastitis, abscesses that return after standard short courses, a draining sinus, granulomatous or cystic neutrophilic pathology, or a microbiology report that mentions Corynebacterium or diphtheroids from a deep specimen. That is the moment to stop treating this like the third episode of routine cellulitis. The diagnostic strategy at that point has to change. And that brings us to Episode 3, the diagnostic trap. Why does the culture keep coming back negative? Why can MALDI-TOF give us the wrong species? And which procedures are actually necessary versus the biopsies and resections that might be avoidable if pathology, radiology, and microbiology talk to each other earlier?